Hello, my name is Stephanie Orient, and I'm an occupational therapist and clinical specialist for the Sheikh Khalifa Stroke Institute at Johns Hopkins Hospital. Today, we will be discussing cognition in the stroke population. During this presentation, we will explore how prevalent cognitive deficits are post-stroke and what the projected recovery rate is, current limitations in cognitive assessment and treatment, how to define the different areas of cognition, focusing on awareness, attention, memory, and executive function, the neuroanatomical structures that relate to cognition, evidence-based practice, and then we will apply these concepts to some case studies. It has been reported that 40 to 70% of patients post-stroke will have some degree of cognitive impairment. Researchers suggest that the wide range is due to lack of a gold standard for cognitive assessment and variation in when during a patient's recovery the assessment is performed. Cognitive impairment is associated with functional decline, reduced quality of life, and increased dependence in activities of daily living. Mole and DeMeyer reported that cognitive assessments that were performed 6 weeks post-injury can predict outcomes at 6 to 12 months. While most improvements in cognition occur within the first 3 months, recovery may continue for at least the first year following stroke. In the landmark REGARD study, Dr. Levine and her colleagues also found that race, gender, and level of education may also affect a patient's risk for developing post-stroke cognitive decline, with Blacks, men, and those with less than a high school education demonstrating faster declines in cognition following stroke. Unfortunately, there is less evidence for cognitive rehabilitation than for motor rehabilitation. Previously used cognitive assessments, including the Mini Mental Status Exam and the Montreal Cognitive Assessment, have been found ineffective in identifying the specific cognitive impairments that occur post-stroke and are therefore inconsistent in predicting chronic outcome. Veterans Affairs and the Department of Defense, in their clinical practice guideline for the management of stroke rehabilitation, reported that there is insufficient evidence to recommend for or against the use of any specific rehabilitation methodology or pharmacotherapy to improve cognitive outcomes. Although this is discouraging, there also hasn't been any evidence that the use of current cognitive rehabilitation strategies is harmful or that it doesn't result in some degree of improvement. Due to the significant impact cognitive deficits have on function, including whether or not one can return to independent living or working, as well as potentially becoming a burden to a caregiver or the health system in general, clearly we must do something to address cognition post-stroke. This also opens the door to future research possibilities. Now we will move on to the specific types of impairments, starting with awareness. Our patients with impaired awareness will be unable to recognize their own deficits, which are obvious to others. Impaired awareness must, however, be differentiated from denial. Patients with impaired awareness will make unrealistic statements regarding their disability or their future plans, will demonstrate significant discrepancies between their predicted and actual performance, as well as less spontaneous error correction, or they may be unable to recognize their errors at all. These patients will also be unable to use feedback to improve their performance. Patients with less insight or awareness will have less motivation to engage fully in treatment because they will find it unnecessary, believing that they don't have any deficits. These patients will therefore require more structure and assistance to learn strategies and apply them in their day-to-day functioning. Impaired awareness is generally related to lesions in the prefrontal cortex, but can also be seen with parietal lesions. Some outcome measures that can assess awareness include the clinician's rating scale for evaluating impaired self-awareness and denial of disability after brain injury, the self-regulation skills interview, the patient competency rating scale for neurorehabilitation, the awareness interview, and the assessment of awareness of disability. The American Congress of Rehabilitation Medicine has suggested using the following algorithm when determining treatment strategies for those with impaired awareness. First, you want to ask, is the patient aware of his deficits? If not, you would use techniques to increase their awareness. If they are aware, then determine if they can use an external strategy. Externalized strategies are those that are external to a patient that someone else could help set up or control, such as a memory book, electronic device, or daily planner. If they cannot use an externalized strategy, you could use the following: a task-specific approach, which focuses on one specific task in the environment it usually occurs. The focus is on the function, not the strategy. While this may result in the patient learning how to do that specific task, they would not be able to generalize the skill to any other task or environment. Errorless learning, where the goal is to not let the patient make a mistake, using cueing and repetition frequently. An example would be, if I want a patient to work on orientation to place, I would say, "We're in Baltimore," then pause briefly and ask, "What city are we in right now?" Spaced retrieval, similar to errorless learning, but now you are asking the patient to remember information for progressively longer periods of time. And chaining, where a task is broken down into steps, and then each step acts as a cue to the step following it. You can use forward chaining, where each step is introduced one at a time and then linked together, adding progressively more steps. Or backward chaining, where the therapist would perform all but the last step of a sequence and then guide the patient to complete the last step. Then the therapist would perform all but the last two steps and then guide the patient to complete the last two steps. If a patient can use external strategies, then you would determine their level of impairment. For mild or moderate impairments, you can use internalized strategies such as visual imagery, mnemonics, or time pressure management, as well as externalized strategies. And for patients with severe impairments, you would continue the use of task-specific approaches and externalized strategies. Some recovery-based interventions to improve awareness include video feedback, promoting error awareness and self-correction during functional tasks, role reversals, where the therapist performs the task and the patient must identify errors, and the use of prediction methods, where you would have the patient predict how they will perform before they do the task and then reassess their performance afterwards. Compensatory strategies to address impaired awareness include the previously mentioned externalized strategies, such as checklists, as well as using familiar rather than novel tasks. Now we will discuss attention. Attention can be defined as the voluntary control over more automatic brain systems so as to be able to select and manipulate sensory and stored information briefly or for sustained periods. It includes the following: focused attention, which is our most basic level of attention, where we can recognize and acknowledge sensory information. Sustained attention, where we're maintaining attention over a period of time. selective attention, which is our ability to attend to targeted information while inhibiting responses to non-targeted information. For example, you're being able to focus on this presentation while ignoring the other sights and sounds of the clinic or office around you. Alternating attention, the ability to shift focus between tasks. And divided attention, which is the ability to respond to two or more types of stimuli at the same time. Driving is an excellent example of divided attention, as you must monitor your speed, your rear view and side view mirrors, and check for pedestrians. Since attention is considered to be a regulator of other cognitive processes, it is suggested that attention deficits may also impair higher level cognitive functions, such as language and memory. Attention deficits have been correlated with decreased functional abilities and poorer quality of life. Patients who cannot sustain attention will likely not be able to participate in motor learning and are also at higher risk for falls. In the acute phase post-stroke, it is estimated that between 46 to 92% of patients will have deficits in attention. This number improves to 24 to 51% by time of discharge from the hospital, but 20 to 50% of stroke survivors will have persistent deficits for years. Our patients with impaired attention will not attend to instructions, may be unable to continue an activity, will not attend to their mistakes, and may focus on irrelevant details and not on the global environment. Impaired attention is usually the result of injury to the brainstem and ascending reticular activating system, including the thalamus. The parietal lobes also contribute to attention. Deficits in higher level attention are related to frontal lobe involvement or of structures on which the frontal lobes are dependent upon for input, such as the basal ganglia. Some outcome measures that can be used to assess attention are the Trail Making Test Part A, the Wisconsin Card Sorting Task, the Rating Scale of Attentional Behavior, the Cognitive Failures Questionnaire, the Test of Everyday Attention, and the Attention Process Training Test. In a Cochrane systematic review of evidence current to 2019, it was found that patients who received cognitive rehabilitation performed better than the control group on tasks that required divided attention. However, this benefit was only seen immediately after the rehab period, with no suggestion that the benefits persist for longer. However, the reviewers went on to say that improving attention, even in the short term, may enable patients to engage better in their rehabilitation and improve their ability to cope with dual tasking, so they considered it to still be a beneficial intervention. Some general recommendations for treating impaired attention include following the hierarchy from focused attention up to divided attention to provide the appropriate challenge. Repetition is critical in establishing a skill to the point that it becomes automatic. And be sure to include tasks that promote generalization of strategies from one task and environment to others. One form of intervention for impaired attention that can also be used to address other cognitive deficits as well is metacognitive strategy training, or MST. This strategy, also frequently referred to as goal, plan, do, review, is based on four main principles. The first is awareness, the patient's ability to acknowledge their deficits or be aware of their abilities. 2, anticipate and plan, the patient's ability to predict performance or outcomes on functional tasks and anticipate plan for errors and obstacles. 3, execute and self-monitor, the patient performs a task as planned, monitoring their performance and having online awareness of their errors. And 4, self-evaluate. The patient self-assesses their performance, integrates feedback from others, and sets new short-term goals. Another intervention for impaired attention is time pressure management. The primary goal of this intervention is to increase awareness of errors and identify how to successfully compensate for slowed processing. As we discussed before with awareness, the patient must first recognize that they have an impairment in attention in order for this strategy to work. They must also be able to recognize and anticipate what scenarios would necessitate use of the strategy and be motivated to do so. It is based on 3 levels of decision making. First, being strategic. Before beginning a task, the patient learns to develop a long-term plan to compensate for and minimize problems. For example, before you get in your car, you decide which route you will take and your departure time. At this point in the task, there is no time pressure present. The second level is tactical, where the patient anticipates events and adapts behavior before time pressure occurs. Going back to our car example, you adjust your speed and what lane you're in to improve your travel time and avoid potential obstacles. At this point in the task, time pressure is present, but it is still manageable. And the third level is operational, where the patient must make immediate decisions and take actions to prevent failure and risk. In your car, you must avoid collisions, decide if you need to take a detour around traffic, all without speeding or running a red light. At this point in the task, much time pressure is felt. This strategy teaches patients to reorganize tasks to account for their deficits before time pressure occurs. So by shifting more tasks to the strategic and tactical levels, it may prevent time pressure from even occurring in the first place. For example, if you make your departure time earlier, choose to travel not during rush hour, pack the car and fill up on gasoline the day before, your chances of running into traffic and being late substantially decrease. 3 stages are used during this intervention, beginning with identifying the problem, teaching the strategy, and then generalizing it to other tasks and situations. Another intervention for impaired attention is use of attention process training, or APT. This technique was found to improve performance on a number of functional tasks and neuropsychological tests of executive function, attention, and memory in the brain injury population. First, an assessment is performed to identify the type of attention impairment the patient has, whether it's focused, sustained, etc. And then the patient identifies which tasks or environments are most important to them, such as being more independent at home or returning to school or work. These tasks and environments will then be targeted for generalization. An example of APT with a patient who has impaired sustained attention but wants to resume home management activities might be: first, start with cooking, which requires sustained attention. Then have them cook while monitoring the washer-dryer cycles. Now you're progressing to alternating attention. Then cooking with children playing in the background, so progressing even further to selective attention. And finally, cooking 2 dishes that require simultaneous monitoring, which requires divided attention, the highest on the hierarchy. Compensatory strategies for impaired attention include use of the externalized strategies previously discussed, such as checklists and assistive technology, as well as decreasing environmental stimuli. Next, we will discuss memory. Memory is defined as the process of encoding, storing, and then retrieving information. It includes short-term, working, and long-term memory, which we were all familiar with, as well as procedural memory, which guides the tasks we perform, usually automatically and subconsciously, like knowing how to ride a bike. Declarative memory, which is purposefully learned, stored, and retrieved, such as remembering your friend's birthday. Episodic memory, which is the memory of everyday events. Semantic memory, which is our ability to remember words, concepts, or numbers, and is required for expressive and receptive language. And perspective memory, which is when we remember to perform a task at some future point in time, like remembering to return a book to the library by its due date. Our patients with impaired memory will not remember instructions throughout the task and may be unable to remember that the task was performed after completion. Potential lesion locations responsible for impairments in memory include the brainstem, thalamic structures, and frontal lobes, the dorsomedial thalamus, frontal lobes, language system, and visual system, the hippocampus, amygdala, and bilateral medial temporal lobes, and the frontal lobes and cerebellum. Some outcome measures that can assess memory include the Rivermead Behavioral Memory Test, the Contextual Memory Test, the Comprehensive Assessment of Prospective Memory, and the Cambridge Behavior Prospective Memory Test. In a Cochrane systematic review of the literature current to May of 2016, it found that patients who received cognitive rehabilitation reported fewer memory problems in daily life immediately after treatment compared with those patients who did not. There was no evidence that benefits persisted in the long term, nor that it improved activities of daily living, mood, or quality of life. However, the researchers believe that even perceived short-term improvements are beneficial and recommended use of this strategy. Some recovery-based interventions to address memory deficits include errorless learning, task-specific training, forward and backward chaining, and mnemonics, which we discussed earlier. Some compensatory interventions to address impaired memory include use of externalized strategies such as a memory notebook or assistive technology, as well as decreasing clutter and environmental stimuli, using repetition, lists, and labeling, and the use of imagery-based training. Next, we will discuss executive function. Executive function can be defined as the mental processes necessary for forming goals, planning how to achieve them, and carrying out these plans effectively. It is the heart of socially useful, personally enhancing, constructive, and creative activities. It includes planning, judgment, time management, goal setting, monitoring, working memory, initiation, task persistence, organization, flexibility, and decision-making. Since I think executive function is harder to define, I like to refer to a study by Walker in 2004, which investigated the progress of 30 participants post-stroke in regaining their ability to put on a shirt independently. They found that those patients with cognitive impairments but no motor impairments could successfully don a shirt. Those with motor impairments but intact cognition were also independent with the task. However, those patients with both cognitive and motor impairments did not regain independence with dressing. The researchers attributed success to the ability to plan, problem solve, and self-monitor, otherwise known as executive function. The group who had no motor impairment were not required to change their pre-morbid dressing method. So even though they had cognitive deficits, since the task only required basic attention and memory, they were still able to complete it. Those with motor deficits but intact cognition were able to use their executive function to problem solve and develop alternative dressing strategies in the setting of their new hemiparesis. However, the participants with both motor and cognitive deficits could not use a routine method, nor did they have the necessary executive function to support this process. Our patients with impaired executive function will be unable to initiate tasks in an appropriate amount of time. They will over-rely on prompts to initiate, sequence, and terminate tasks. They will have difficulty organizing tasks, as well as decreased efficiency during task performance, and will have difficulty solving problems. Deficits in executive function can be related to lesions in the prefrontal cortex. Some outcome measures that can assess executive function include the Executive Function Performance Test, the Behavioral Assessment of the Dysexecutive Syndrome, and the Multiple Areas Test. Recovery-based interventions to address executive function include problem-solving and planning training, self-instruction training, goal management training, time pressure management, and self-regulatory training, which we discussed earlier. Compensatory strategies to address impaired executive function include the use of externalized strategies such as assistive technology, memory books, and external cues. Next, we will review some emerging evidence in the realm of cognition, as well as some general treatment recommendations. I included this recent 2020 article as it is an emerging area of research investigating the effects of aerobic exercise on cognition post-stroke. In this study, they looked at 50 participants, ages 50 to 80 years old, who were greater than 1 year post-stroke. The participants were enrolled in either a 6-month aerobic exercise program or a 6-month balance and flexibility program. They concluded that females who participate in aerobic exercise may experience a positive effect on selective attention and conflict resolution compared to their male counterparts. As more research emerges in this area, it may shape how we schedule or plan therapy, such as having our patients engage in aerobic activity prior to performing a cognitively demanding task. The overall goals of cognitive rehabilitation interventions include increasing awareness of patients' deficits, integrating the use of externalized compensatory strategies, progressing to internalization of strategies, and generalizing skills to other environments and tasks. The stages of cognitive rehabilitation include acquisition, where the patient is introduced to the strategy and has begun to learn how to complete the targeted skill correctly, but is not yet accurate or fluent in the skill. The goal in this stage is to improve accuracy. Examples and personal stories can help the patient recognize how they may have already used this strategy in the past, thereby improving their motivation to use it again. The second stage, application, where the patient is now accurate and fluent in using the targeted skill, but does not typically use it in different situations or settings. Or the patient may confuse the targeted skill with similar skills. The goal of this stage is to get the patient to use the skill in the widest possible range of settings and situations, or to accurately discriminate between the targeted skill and similar skills. And the third stage is adaptation. The patient is accurate and fluent in using the skill, including applying it in many situations or settings. However, the patient is not yet able to modify or adapt the skill to fit novel tasks or situations. In this stage, the goal is for the patient to be able to identify how to adapt to new demands or situations. Some other general treatment recommendations include: avoid repetitively teaching the same activity in the same environment, practice the same strategy across multiple tasks, and practice the same task and strategies in multiple natural environments. This is especially important as a patient's performance on paper, pencil, or simulated tasks does not always translate to real-life situations. And that leads me to this quote from the American Congress of Rehabilitation Medicine, which I think should be at the heart of all of our rehabilitation interventions. That is, the ultimate measures of success are improvements in real-world adaptation, including managing work and daily living or leisure time activities, as opposed to improvements in therapy exercises or test scores. We owe it to our patients to make sure they are doing more than just passing tests and improving on outcome measures, because they might still end up failing in life if we do not provide them with and prepare them for real-life situations that they will encounter upon discharge. When monitoring progress during cognitive rehabilitation, we should create a detailed record of performance. We want to record not only the number of errors, but what can explain variations in performance. When a particular strategy is shown to enhance performance, motivation to use this strategy may be increased. Or, if performance deteriorates after several trials due to fatigue, this can help patients develop in-the-moment awareness of how and when fatigue begins to impact performance, so they can initiate a rest break. We also want to focus on big picture progress, identifying and recording personally relevant milestones, facilitating motivation and instilling hope, and avoiding feelings of defeat. Now we will review some of today's concepts. True or false? If a patient is not aware of their deficits, you should teach them to use internalized strategies. The answer is false. You should first use techniques to increase their awareness. True or false? Repetition is unnecessary when addressing attention deficits. The answer is false. Repetition is essential in order for skills to become automatic. Which of the following can be used when addressing memory deficits? A memory book. B, forward and backward chaining. C, errorless learning. Or D, all of the above. The answer is D, all of the above. A common strategy used to address problem solving is goal, plan, do. A, try again. B, review. Or C, start over. The answer is B, review. A patient is using time pressure management to cook a meal. What should they do before cooking, during cooking, and then in the case of overwhelming time pressure. Before cooking, the patient should read the recipe thoroughly, decide what can be done first, prepare ingredients and place items within reach, and turn off the TV and phone to prevent distractions. During cooking, they should avoid distractions, even when they have to wait for water to boil. And in the case of overwhelming time pressure, such as the doorbell ringing, they should turn off the stove and then answer the door to prevent the food from burning. A patient has poor awareness and attention. What are some strategies that could be integrated during gait training? You could have the patient predict their performance, such as asking them, will you need help? Will you lose your balance? How long will it take you, or how far will you walk? Then you would have them walk and then review their performance afterwards. Once the patient has become successful with gait training, you would want to apply the strategy in new and more difficult situations, progressing from a quiet room to a cluttered bathroom to a crowded hallway to uneven surfaces. What are some ways you can integrate family and nursing into cognitive rehabilitation? If appropriate, you can introduce the concept of a memory book and encourage family and nursing to write down information in it and have the patient refer back to it to recall important items. Teach them to decrease distractions. Allow the patient increased time to complete a task. Use forward or backward chaining or errorless learning if appropriate, and be sure to celebrate successes. Thank you all for your time and attention today. I look forward to seeing you all at the upcoming Q&A session.